So these are the very much occupational therapy based questions. Number one, what do you think of weighted cutlery and lipped plates, etc.? And then we had a same question again, any special cutlery?
Okay, they absolutely serve a purpose is where I'm at, but it depends on the individual. It depends on how they feel about using them. It depends on the stage of the illness. So certainly I would be exploring them. I suppose a massive thing for me working in the community is that these things cost. And once upon a time, as an OT, I used to be able to prescribe these things, but I can't anymore. The government guidelines are such that actually individuals are required to purchase their own, and that might cost them a small chunk of money. And there used to be places that perhaps you could go and try them out, such as independent living centres, but again, they don't exist as much as they used to. So it's a question of, okay, how can you, what sort of, I suppose, core items do you need to have in your HD toolbox? And I would suggest that things such as Dyson, which is kind of a non-sticky mat, which is a terrific product that you can purchase, which will stop items such as cutlery or bowls skedaddling when they get knocked by the individual with somebody with Huntington's disease. I would suggest that deeper plates and deeper bowls are used. So the person has asked about lips on those things. Absolutely, you can purchase those to give, if you like, additional height on the side of the bowl so that you can push the food and then manipulate it up onto the cutlery. So those really do work. But if you don't have the ability to purchase those, sort of very deep pasta bowls work really, really well. So they're nicely sat on your Dyson mat. And then the other thing that I would suggest is we talk about weighted cutlery. Weighted cutlery is fine if the problem is about a mild to moderate tremor. But don't forget that, of course, in HD, we've got chorea, i.e. the dance-like movement, but we've also got dystonia, which is a spasm. And often you might be dampening the tremor with your weighted cutlery, but actually it won't necessarily prevent against spillage due to spasm or chorea. So, I mean, that has to be more about positioning and then protecting clothing, those kinds of things. But if we're talking about problems with fine motor movement, so people often talk about the inability to hold on to thinner cutlery, for example, a really cheap option is to actually put pipe lagging onto the handles of cutlery to build up, if you like, the surface area that you're holding on to. Another thing that's available, and again, it dampens tremor, but it doesn't necessarily dampen spasm or chorea, is actually weighted gloves or weighted wrist cuffs. And because they're that much heavier, actually that will really, really dampen down the tremor. But again, be a little bit wary because not everyone likes them. They're also incredibly fatiguing on the end of an arm that's already struggling with energy. There are some very clever items out there. They're incredibly expensive though. So for example, something that used to be called the Google spoon, because Google bought the rights to it, I think it's called a lift-able spoon. It also has a fork attached to it, has a device within the handle of the cutlery, which again works to dampen tremor and can work quite well in mild to moderate tremor, but again doesn't work with quite severe tremor or severe spasm. I think Kirsty and I also spoke about things such as having the cutlery actually attached to your hand with Velcro. Again, that can work for people when you have a sudden urge to let go of the cutlery. So that can also give a sense of control for the individual. And then I suppose if we work outwards, we're talking about things such as making sure that you're actually covered so that your clothing isn't getting soiled. And that's really, really important for people. We're also talking about seating, which we'll mention later on. Again, from a biomechanical perspective, a really good position to sit in is a 90-degree angle. And then you can actually place your elbows, for example, on the table, and that can actually dampen chorea and tremor and dystonia. But we're also thinking about the floor space surrounding. So, for example, I've got people who've had offcuts of linoleum on the floor underneath the table, so then it's wipeable, downable. So there's just all of those kinds of quite low cost things that can assist individuals.
And I think the only thing to add, Alex, is as occupational therapists, we do want to help someone maintain their independence for as long as possible, and that's core to occupational therapy. But also from our speech language colleagues, we know that if someone can manage to feed themselves, they're at less risk of aspirating. So we really do want to promote someone maintaining their independence for as long as possible. I know when I've worked with people and we've looked at built up cutlery and we looked at straps on a fork or a spoon, at that point the person is actually been happy to let us put some hands on, and it might be they start off feeding themselves, and then as they fatigue they might actually accept some hands-on gentle facilitation, so they're still doing the action with us assisting them, and that's safer than a member of staff taking over. So if possible, but things change quite quickly as well, so we were hesitant to say go out and buy all these aids and adaptations because we are looking at a progressive illness. However, if they can maintain independence for a bit longer, then that's fantastic, and that's what we would be looking for achieving. Okay, and then another very OT question: how can I help to make my husband comfortable when seated? The only time he's properly comfortable is when he is in bed. And this is one of the ones we talked about this morning. And if I was looking at this gentleman, I would be really interested to see how he presents in bed, what his posture looks like in bed, and can we replicate that in seating, for example. So it might be in bed that his pelvis is supported and his trunk's supported. And as soon as we put him in a standard chair, if he doesn't feel safe or he's not able to sit, as Alex was describing, sitting in a chair where you've got an upright back and a seat, so you've got to have a 90-degree at your hips and 90 at your legs and your feet. If he can no longer manage that posture, he's going to be really uncomfortable in a standard chair, or he's going to try and slide to get comfortable. So it's really understanding biomechanically what's happening to try and understand why seating isn't suitable. And we talked about assessment. We talked about an occupational therapist coming out and doing a assessment of seating.
Yeah, I think we spoke about the thing about chairs. If individuals do need specialist chairs, that can be a real bone of contention for everyone from a finance perspective. So you can have an occupational therapist come out, and I would hope that most OTs do have basic seating assessment skills, but if they don't, they usually know somebody who does. But then it's about who pays for that. So it's about then liaising with the Huntington's disease advisors as to who your local OTs are and what the provision is like in your local area. So, for example, in my local area, I might see you, for example, if you've been referred through the Huntington's disease clinic, but it might also be an OT from social services, or it might be an OT from a community rehabilitation team. But we're still all drawing on the same stock. So, for example, Birmingham City Council will actually, we can purchase specialist seating through them for individuals in the community. However, I know, for example, if you bob over to Warwickshire, or you bob over to Herefordshire, that might not actually be the case. And so therefore there are kind of layers and processes that you need to work through in order to get the seating that you require. For me, this is actually a clinical need. It shouldn't really be coming out of people's private purses. And I will always argue the case as much as I can for statutory provision. Seating is so important to so much function. If an individual is comfortable, it doesn't just affect eating and drinking and minimization of aspiration and promotion of swallowing. It also enables interaction with the surrounding environment and the people in those environments as well. So yeah, seating is really, really core to people with HD.
Yeah, and I think it's also important to say, Alex, I'm sure you'll agree, although we would recommend eating and drinking in the chair in sitting, but actually if the seat isn't suitable, then actually you might get a better posture in bed. Sometimes there's a feel of you must never eat and drink in bed, but actually if you can get a good posture, and you're in a profiling bed where you've put the knee brace on and you've brought someone up to 45 or as upright as possible, that might actually be a better posture than a chair. So you're looking at someone being in midline with their head supported, or head upright, supported if required. So there is no right or wrong in terms of where you're sat. It's getting the optimum posture. And we're talking about eating and drinking, but actually posture is also really important for PEG feeding as well.
Yeah, absolutely. Yeah.
Okay, so the next questions we've got are not pure OT questions, but we certainly are going to give some advice on them. So, question: any suggestions on how to ease someone from eating solid bread, crisps, etc., to eating less bulky food suggested as soup maker?
Okay. Yeah, okay. I'm gonna just go with the last bit about soup makers. There's a let me just see. It's the Huntington's Disease Society of America have produced a guide on eating and drinking. And within it, it refers to blenders and juicers, but it doesn't refer to anything specific. So I don't think we can actually say a specific make for you, whoever posed this question. I'm very sorry. But of course, the point being that if you're aiming towards pureed food, or if you're aiming towards a specific texture, sometimes some of these devices do not puree to the extent that you get the smooth texture that is required via for dysphagia management. So I suppose what I would do is, and this is getting to the beginning of this question, is actually don't be dealing with this issue by yourself in isolation. If your loved one has signs of dysphagia, and that's coughing, for example, or gurgling in the throat, those types of issues which will happen, then as soon as that happens, start to get involved with a local speech and language therapist, who will then in turn give you advice on the transition from the harder textures to the softer textures. There is, however, if you are not in touch with a speech and language therapist, although I would be recommending you to be in touch with a speech and language therapist, is a website, which is designed by Nestlé. And if you typed into your Google search engine, Nestlé dysphagia, you will come up with the site. And then there's some really good dysphagia advice on there for carers, which is what our colleagues in speech and language therapy use as a standard. And you'll see that they refer to a particular standard, and all of the altered textures of both liquid and of food are referred to on there. But there are recipes on this site that also our colleagues will refer to. I suppose the other thing to say is, because we're on a HDA webinar, is that actually there's a really good publication on the HDA web, Eating and Drinking Well, I believe it might be called. Is that right?
Eating Well Guide, yes.
Eating Well Guide, there you go. Yeah. And I hope that answers the question for that individual. I know the webinar is entitled Eating and Drinking in HD, but we're coming from a very sort of functional activity perspective. However, we do have a duty of care to sort of point you in the right direction, which is speech and language, dietitians, and also good dysphagia advice.
And what's really nice about the Eating Well Guide is it very nicely reminds us all of what to look out for, early indications that someone is having problems with eating or swallowing, which speech language would term dysphagia, and just reminds us that some of the signs, such as the coughing and choking, can happen during a meal, but also after a meal as well. Or an indication might be that chest infections or pneumonia, when you hear professionals talk about silent aspiration, you might not see somebody struggling with their eating and drinking, but they're getting more frequent chest infections, which would suggest that food is going into the lungs and not all being swallowed. So a really nice guide.
Yeah, I think actually on that point, you talked about silent aspiration, and I know that we're talking about food or fluid consumption. Let's also remember here that people with HD can sometimes produce additional saliva, and often or not, sometimes when you've minimized everything else, actually sometimes it can be the production of saliva that might actually be going down the wrong way as well. So it's also worth addressing that.
Okay, still looking at speech and language therapist here for the answer to the next question. The question is, have you any advice on taking tablets as swallowing becomes more difficult? So that comes up a lot. So I'm glad it's been mentioned, although we're not going to answer it purely as occupational therapists, but it's something that does happen and can also get missed. A lot of focus can be on what level of food someone's on, what level drink, and then they're still swallowing a tablet. So we again are going to ask you to refer back to speech and language therapist. Certainly if you can't get hold of someone, speak to the HDA advisor. Whoever's prescribing the medication as well. Who's
prescribing the medication, absolutely, because there are alternatives. Yeah. There are alternatives. So there'll be liquid alternatives, there'll be melt in the mouth alternatives. Some aren't available, but most of them are. And cost should not be used as an issue here. So actually, if your loved one, yeah, absolutely, Tammy, you should talk to the pharmacist. Yeah. Again, that's a really good point. Actually, pharmacists don't get used enough, and they're terrific. Really good point actually about that is recently I had somebody who wanted their medication in a blister pack, but we weren't quite sure whether they could operate the blister pack. So actually, I spoke to our pharmacist and they sent us a blank one. So we were able to actually just have a go until the individual felt comfortable with both the days of the week, but also how to operate it. Great, really good point.
Some tablets can be crushed, but not all tablets, but certainly I've worked in environments where tablets which can be crushed have been, and they've been put in food or some yogurt or some jam, different ways of, but that's all being done under the guidance of the speech language therapist and for me, the on-site pharmacist. So thank you for that, Tammy. Okay, this one Alex is going to answer because she's got some hot off the press information for it. Are there any suggestions for non-symptomatic Huntington's disease patients to delay the onset? Any type of diet, intermittent fasting?
Okay, so what we tend to do in the mornings is we tend to look through the questions and then we go away and we do our homework. And so I went to talk to our Huntington's disease dietitian, Jude, today when we saw this question. So I think this is the science bit, as they say on the advert. Okay, so number one, a person with Huntington's disease at whatever stage of the illness, but particularly in the early stages of the illness, there have been papers to show that they need an additional at least 11% more energy requirements than an individual without Huntington's disease. Now, energy, I mean in terms of calorie intake, because the individual with Huntington's disease is struggling to produce energy of their own. And that's a problem with HD metabolism. Metabolism is the rate by which we burn off at a cellular level and a calorie level. So number one, people with HD need additional calorie requirements. So that's the problem that we've got when we think about dietary interventions such as intermittent fasting. So intermittent fasting, okay, is a method whereby you go a number of hours without taking on board anything other than perhaps water, for example, and it can be an extended period of time. And what that does is that stimulates the body into burning off calories and cells, okay? And that's why people lose weight. So these are people without Huntington's disease, okay? But what we've also noticed, and there have been some papers on this, is that fasting of mice, so this is not human beings, by the way, fasting of mice shows that intermittent fasting or diets equivalent to intermittent fasting will burn off or attribute to what's called autophagy. And autophagy is the destruction of dead cells within the body and the brain. And that includes mutant Huntington protein. So you've got a dietary mechanism that can be applied to mice that potentially reduces the nasty proteins that cause Huntington's disease or are part and parcel of Huntington's disease. So you might naturally go, okay, intermittent fasting in an individual with Huntington's disease is going to burn off or help, if you like, slough off the Huntington protein. But let's go back to point number one, that actually the individual with Huntington's disease needs additional calories. So you've kind of got two opposing things going on there. But so when we get back to the little mice, what tends to happen is starvation or fasting produces a thing in the brain called ketone bodies. And people have heard of ketogenic diets. So what the boffins have done is they've kind of gone, okay, so we think that we can replicate this ketone by introducing an oil, and it's got a particular name, and it's on, by the way, HD Buzz. and I'll try and find it for you in a moment, because all of the boffin stuff is on the site HD Buzz. And so there have been very, very small scale studies where scientists have introduced into humans, okay, with and without HD, this particular oil that replicates this process. And they've noticed that it increases energy, which is what we want. But it was a very, very small scale study. It wasn't what's called blinded, so everyone kind of knew what they were taking. And so far, the evidence is kind of sitting sort of in the mice domain rather than really in the human domain. And so when speaking to my colleague Jude about this morning, she was like, okay, people are starting to look at it because it's really worth looking at it. But actually currently, it's not standard practice within Huntington's disease dietary management. I hope that makes sense. You can all wave at me and say yes or no, because it was a real science lesson for me this morning. Professor Sarah Tabrizi, who is obviously one of the lead players in the HD trials, has actually written a paper, I think it was 2015, on the fact that all of these things should be explored, but they need to be explored safely. And currently they're not there in mass blinded trials. So Jude is very much sort of, please do look at the eating well guides. Please do include antioxidants in your diet and have, if you like, draw on a good range of supplementation within your diet. Does that answer your question, whoever posed it?
I hope so. Thank you, Alex. That was really useful to speak to her this morning, wasn't it?
Yeah.
Someone's not asked any questions, but just saying, the information is really useful, as her husband, son and stepdaughter have Huntington's disease. A speech and language therapy question: are there certain foods that trigger choking at an early stage, or is it particular to each individual?
Okay, again, we will refer you to our speech and language therapy colleagues for this, but as a rule of thumb, if somebody is coughing on particular textures or sizes, and because dysphagia does happen within the range of symptoms that you're going to experience in this illness, then actually it's really worth seeking their advice, because actually it does tend to be, as you've already pointed out, it can be quite individual, but there are certain standards as well.
I guess as occupational therapists, we might be looking at the wider issue of the environment that someone's eating in. Is choking happening because it's too much happening in one time? Carers are speaking or family members are coming in, and attention isn't being focused just at the point of taking the food from the fork to the mouth, chewing and swallowing. If someone's trying to ask questions and you're trying to respond, that's doing two things at once. So
it's quite interesting actually, because I went to see a chappie yesterday, and he's coughing on a range of textures and a range of liquids, and we can't quite hone it down. And actually, when we were looking at it yesterday, what it was actually it was the rate of feeding, and so the gentleman knew when the bottle with the feed in hit his lips, he would then suck on it. It would go into his mouth, but at that point he had, it was then at that point that it stopped. And I suppose what you would call pooled, but it wasn't actually pooling. It was almost like waiting at a station until it pulled out. He needed another 10 seconds, if you like, to process the fact that it was in the mouth, and then it stimulated the swallow. So sometimes it's also about speed. And so what was happening was he was coughing because the speed at which it was being given to him was going into his mouth. He didn't have the opportunity then to clear his mouth, swallow, and then start again. So if you like, there was almost like 1 or 2 feeds then within his mouth, which then caused him to cough. So it's about the small adjustments like that as well.
Yeah, I certainly have worked with people who have not been able to monitor what they're doing. So monitoring, and they're cramming and putting too much into their mouth, and actually slow down, the food texture has been okay, but left on their own devices without someone externally slowing them down, and then that becomes the risk. So there's so many factors involved in eating and
drinking. Definitely. I was just about to say something along those lines. I think, eating and drinking is such a personal, a very intimate activity, isn't it? And actually it feels really quite invasive, if you like, slowing somebody down with their consumption of their food. But let's not forget that, as Kirsty says, this individual has perhaps lost the ability to self-monitor the amount of food that they're putting in. But they've come to the table, and actually it's not until the food actually comes in front of them that they realize that they're hungry, because they can't self-monitor their hunger. And therefore, at that point, they realize that they're really, really hungry, and then they want to cram. Yes. So, and of course, at that point, when they cram, there's too much going in the mouth, and then we've got coughing and choking going on.
Big risks. Okay. Do you have any tips for maintaining a healthy weight without creating anxiety for the HD sufferer? So we talked about signposting to the dietitian in terms of appropriate foods, in terms of high calorie foods. We haven't really talked about supplements, but supplements are available on prescription, which offer high calorie content and proteins as well. And we talked about the anxiety and feeling hungry, didn't we?
We did. So we weren't quite sure where this was coming from. So sometimes, because the individual with Huntington's disease confuses the signals as to what that might mean internally in their bodies, and that's called interoception. So today is a real science lesson. So if you can't understand that you're hungry, it might actually present as anxiety. So, everyone knows the advert with, what's his name, who plays Mr. Bean, and it's talking about having a Snicker because they're actually being a diva. It's, if you think about it, it's very much that sort of hangry-ness that's going on, and it's also anxiety as well, can be around being hungry. So it's really important to check out what the cause of the anxiety is. If the cause of the anxiety is, of course, actually eating and drinking because you're then fearing choking, then of course it's really important to work very closely with both the speech and language therapist and the dietitian combined. And usually they do go around in pairs, well, certainly at least my colleagues do, because you can't separate the two really. And so therefore it's really important to kind of work out what's going on. I mean, folk with HD, they will have had problems with food even before they developed the overt symptoms of Huntington's disease. So people very aware of their image, their body image. So we have people who have had eating disorders prior to developing problems with HD. And so that can be really, really hard. So it's about knowing all of those factors and putting them into the pot and trying to work something out to try and retain a healthy-ish weight. And with our dietitian colleague Jude, she's always saying to people that you can't go with your standard BMI. You always want to be looking at the upper end of the BMI for somebody to manage things like hangriness, but also so that the individual has a little bit of extra weight, so that when it comes to problems when they're poorly or perhaps not eating as much, then that can be managed. She also says little and often. Don't think about standardization of food. We eat in a very traditional way, don't we? We have breakfast, we have lunch, we have an evening meal. Sometimes it's okay to eat out of those times, little and often. You know what? Jude always says to me that 10 milk chocolate Aeros at midnight is absolutely fine, providing that person is eating them.
And certainly our dietitians are very skilled at being able to ensure that feed's got a higher calorific content than what we would have as a normal population, I guess. So, for example, soups, put cream in them.
Don't be afraid.
Milkshakes, you know, really high calorific milkshakes, things that you might have, you know, on a special occasion. These are always in the fridge. Certainly the wards that I've worked on, you know, pots made up of milkshakes with chocolate and cream and as many calories as possible. If someone is, that's, you know, they're having that between meals and we want to keep their weight up, that's what
Jude always says to me as well that people get really, really worried about heart disease and diabetes. Yeah, folk with HD do have those actually, but actually to a lesser extent. And the important thing is to keep the weight on, because it maintains condition and it maintains function. So yeah, work with those wonderful professionals.
Okay, and our final question. What are the signs that a PEG may be the next step? We looked on the HDA website at the living guide. I say living guide. I think I called it something.
In the Eating Well guide.
Eating Well guide. See, I've now forgotten what it's called. And that's got a really nice section on there about PEG. And yeah, there's medical discussions that will happen.
For whatever reason.
Potentially happen with healthcare professionals about nutrition and oral supplements, and making, you know, when it's right to make the decision to consider PEG feeding. And on the HDA website, they look at 2 points. One, is the person no longer safe to swallow? And two, is it possible to meet their nutritional needs anymore? And if it's not, that's when discussion will take place about PEG. There are talks on there about the challenges of not having these discussions early on. So it's really, really important to have discussions when someone still has capacity, or even if not capacity, still able to make their voice heard about their thoughts on PEG feeding or not. Certainly I work with individuals who we class them as the risk fed. So we feel that their swallow isn't safe, but they don't want to have a PEG. So that's the risk that they've chosen to take, or it's been taken in their best interest. Really, you know, difficult discussions to be had, but really important all the same. And any discussions which are had early just makes it easier later.
Oh, definitely. Of course, some people aren't at a point where they wish to discuss them, but they might wish to discuss about others that they've seen with PEGs. They might wish to discuss what their wishes and feelings and their values are in life. So don't be afraid to have those discussions. Of course, sometimes what happens in sort of perhaps mid to late is when you're having those discussions with people, they're actually they're unable to cognitively future think anymore, and they're very much living in the moment. So again, family members and loved ones, have a gentle conversation, log it away in the back of your mind. If you're working with somebody, with your GP, or if you're working with anybody else, make sure you document it, because actually it might have seemed quite irrelevant at that point, but actually it's all very relevant. Because often what we have to do is we have to go through our notes and we have to go, oh gosh, did they mention this to anybody at any point at all? It's really, really important we consider that. What we often find is that, having that conversation gives people a lot more control, And it also then takes the pressure off loved ones as well to be making that decision. But that decision will never be made, will never just be forced on one person. I think that's important to say.
Yeah. I'm going to share my screen.
Okay.
Time has ticked on really fast. The whole webinar is being recorded, so will be available. So we've just going to flick through some slides that we've put together just to go over what we've talked about. I mean, a lot of the questions means that we've answered most of these. So why eating and drinking becomes more difficult? It's very much considering as professionals the stage of someone's illness, and we've talked about the physical changes, we've talked about the need for someone to need more calories, we've talked about physically career movements, grip, holding, cutlery, coordination. That's physical. We're also thinking about someone's posture, ability to sit in a chair. But we've also touched today on cognitive changes, monitoring what someone's eating and drinking, psychological changes, being aware that someone's hungry, or if someone is depressed, for example, then eating and drinking becomes less important. So there's so many factors, and we do this every fortnight. We talk about how we can't separate the physical, cognitive and psychological changes, but they all potentially have an impact on why eating and drinking does become more difficult. And as you've said, Alex, eating and drinking is such a social, such a pleasurable experience for the majority of us. We eat and drink because we have to, but actually there's a big social element to eating and drinking as well.
Actually, when you think about, what's just happened with the sort of the just loosening of the lockdown, what's the first thing? It's about hospitality, isn't it? And it's about going out and eating and drinking right there. Yeah. It says it all. I mean, we've had, so for example, almost like in partnerships, husband and wife partnerships, where they've been used to going out eating and drinking together, but actually a person becomes quite aware that they're almost embarrassed of their skills, and so they will withdraw because of that and become quite low. So again, it's really important to think about the timeline of these things happening, and then actually having perhaps your husband, who used to be the boyfriend many, many years ago, the last thing that you thought about was the fact that he might be facilitating you to eat and drink. So it's really, really important that we consider all of that.
Yeah. We've talked about the occupational therapy assessment. We've talked about posture, fine motor skills, grip, coordination, career movements. So an occupational therapist is very much observing performance and then looking at how we can maintain independence and function. And we've talked throughout the questions about working alongside other professionals, your speech and language who work really closely together. I've put physiotherapist. I've certainly worked with people with late stage HD, and it's needed the whole team to really get together and to think, how can we best manage someone because of their safety. It comes down for me at that point, how we reduce risks of choking, silent aspiration. I'm going to move on quickly because we're going to run out of time for the presentation. So we've talked again about different types of equipment, and I've just put some slides together of the photos. I'm very visual. So we talked about having a strap, so trying to keep someone's grip onto a spoon there. There's a picture of a bowl with a lip side. The middle photo is the spoon that Alex was talking about, and I've forgotten the name of it now.
Oh, I call it the Google spoon, but I think it's got another name. And actually, the Google spoon could only be purchased from, we used to be able to get it over here, but actually can only purchase it through the USA now. And it's something approaching $400. But there is a version that's produced by a Chinese organization. And I think the details, and I'm sorry to advertise another organization, but the Tremor Foundation will have information on it if you're interested.
And I think if you put Parkinson's as well, in
Parkinson's as well, yeah, absolutely.
Search, you'll find, and then you can see, I will just put on there a huge range of different types of cutlery, weighted and built up as well. But bear in mind that you can, you don't have to buy the exact cutlery with the handles on. You can do Blue Peter style and get your pipe lagging to build up the size of a grip, and we haven't got a photo on there, but also consider this, the what the spoon is made of. So quite often, if someone's got a lot of dental problems, I wouldn't be prescribing a spoon with, which I'd be looking at a plastic spoon, sorry, not a spoon that we can see there. I've lost my words now. So you're not going to cause any damage if someone's having problems coordinating or, you know, banging the spoon into their mouth.
Yeah, because you can sometimes splinter in your, it can splinter in your mouth. So there are spoons that are made of what's almost like an anti-spasm material.
Yeah,
that are quite soft and won't crack.
And biting, that's something I've experienced, is someone biting down. So yeah, we don't want it to crack. And if someone is eating too much, crumbing, a smaller spoon, you know, something, it might be just simple as going from a dessert spoon to a teaspoon, if someone's eating really fast. Drinking, just a selection of cups on there. Thinking about, again, grip, holding a cup, one handle, two handles, no handles. Does the cup need to have a lid? These aren't particularly attractive cups, but you can get some nice looking cups which aren't made of china if someone's dropping. There's some nosy beakers there, so if someone has got more difficulty in putting their head up to eat and to drink, then that could be useful. And there's a non-spill cup on there which can't be knocked over, so you have to physically pick it up directly up to lift it up. Straws as well can be used. I personally would never recommend any drinking utensil without the speech and language therapist being involved, because they're looking at the speed that liquid's coming out. So we work hand in hand. Alex talked about the Dyson mat on a roll. There's a roll there, really, really useful. All OTs have those, have some Dyson mat in their toolbox. You talked about plates. There's a cheap option there, is a plate guard. Alex talked about bowls, big pasta bowls, and there's a sloped dish there as well. So all equipment is available. I suggest having a look at on Nottingham Rehab Supplies. It just gives you an idea about what equipment there is available, and the prices as well. I've lost you, Alex.
Yes, all right. Nottingham does tend to be a little bit expensive. Sorry for those of you here that you might be like, okay, but you can then look for a cheaper alternative. And it's just about getting ideas.
Okay. Posture assessment. So we've talked, haven't we, about maintaining, oh, I've gone too fast, maintaining a upright posture, not only during eating, but after eating as well. So try and encourage someone to say just to remain upright for 15, 20, 30 minutes if possible after a meal. If the person's in bed, make sure the head end of the bed is raised.
Not always possible. It is not always possible. We've got people that just literally want to be flat. So we'll just try as best as we can. Again, the gent yesterday, he actually had to be held in position because his career is quite bad. So he actually has to be gently supported by two carers whilst they're facilitating. And we're just looking at ways that we can try and keep them as upright as possible, but it's not always possible. But it's just about reasoning it through.
And I have put on there about the supporting need for the carer. So I'm glad you said 2 carers to support someone. I've worked in environments where a lot of carers were care feeding, and I was concerned about their postures, and we actually ordered some perching stools, and the carers found that much more comfortable. So it's not dignified for someone to be standing over a person offering a meal, but actually you also, so we want the carer to be sat down, but they need to be thinking about their backs, and we felt that the perching stools worked quite well. They don't take up too much space, and you're slightly higher than the person, so that works. So think about your patient and the staff. I had another resident who took about 30 minutes to have a small beaker of water, and she needed her head holding. Didn't matter what we put in place to support her head, she actually needed gentle facilitation. That was really fatiguing for her and staff, so we would swap staff in. It took so long. So fatigue management, if you can allow the person to or encourage a person to eat and drink when they're most alert and well rested. I certainly see that the breakfast meal is the meal that an individual has the most of their food, and then as the day goes on, they are really just having less and less and snacking, and actually that works for them. And Alex is talking about small frequent portions. Food is always available in all the care environments I've worked in. There's set times for a main meal, but there's always food available for when someone wants it. Always. Small frequent meals.
Yeah, I think I mean, I have worked in sort of specialist environments like yourself, Kirst, and sometimes it was like, well, we can't produce food outside of regular hours, and I was like, well, actually that's not acceptable. That's about the institution, that's not about the individual, and this is about an individual who's struggling to maintain weight. So use good clinical argument.
Yeah, so important. We've talked, haven't we, already, about reducing distractions, not having conversations. You've just said it, Alex. What's must be individual to the person. What works for them. Make sure there's choices, and have food, drink visible if initiations occur, and if that a concern, if the person isn't, you're concerned about them not eating regularly, bring the food out, have the food on the table, bring it through a visual cue reminder.
Yes, I mean, because we talk about initiation and termination of movement, this is about, if we take that concept, it's about initiation and termination across every activity. You'll see that occurs.
Yeah. And you've mentioned this. I put on here about pacing doing activity, and it's really hard. I've worked with people, I've been care feeding, and they're opening their mouth and they're ready for the next one, but they haven't swallowed. So I always say to care staff, it's real skilled intervention to safely feed someone or to safely offer someone food and drink, and it shouldn't be rushed. And don't underestimate how skilled that is to recognize when someone has swallowed and when to offer them the next mouthful.
It's a really, really good point. I was attending a continuing healthcare decision meeting this week, and it hadn't been recognized, the skills that the individual required in order to feed them safely. And that was, we classed it as a high need because of the skills level. So again, when you as an OT perhaps are writing these things down with your SLT colleagues and your dietitian colleagues, make sure that you are putting that down as well. Anyway, matey, I'm conscious that it's 27 minutes past.
Yeah, so we've touched on legal considerations. this is the resources we're talking about. So I've just screenshotted. So do look at the HTA Eating Well guide and also the Nestle guide as well. And we have done.